Hello, can you hear? Hello, everyone. I see. Can you hear me?
Yeah.
Yeah. Okay.
Welcome, guys. Nice to meet you. It's the first time I attend one of your meetings.
Okay.
But I'm going, if you've seen my profile on LinkedIn, I'm quite invested into neuroscience and neurophysiology, all of those. But for me, everything is connected. So you cannot go with only one without thinking about the others. They do interact. It's a matter of understanding how the brain works. It's not just a network. I was thinking about something a couple of days ago, saying that I used to say that the environment, whether it's a micro environment or macro environment, it shapes an individual, and it shapes it in a way that what shapes most an individual is the adversity.
I totally agree. We'll wait. Oh, we can talk now, but we'll wait for like 5 more minutes for everyone to go in. But you can continue. I just want to make a point that people get me mistaken. I never said that brain means just brain. You know, the brain we have this concept of experience-dependent plasticity, meaning that the brain is all the time actually interacting. Actually, it's being organized by the environment for the most of it. So I don't want to get not understood well. The fact that I'm concentrating on networks does not mean the networks are actually representing the environment. So the environment is very, very important.
Well, like I've seen on the video, it is true. Everything has some sort of a shape, natural shape, and it is also Fibonacci, all those shapes that we see in nature. It's what strikes me. It's nothing is symmetrical. Nothing should be symmetrical except those patterns. They are infinitely. So that's the. It's really intriguing because there's nothing alike. There's not two individuals alike. Not even two plants alike. But the shapes they have, it's unique. But they share patterns.
Do you see patients in a clinic like?
No, not really. I'm a thinker. I'm a self-made man. But I've been in there doing psychology and stuff like that. I started neuroscience in 1992. But I stepped on question: what has to do with physiology and endocrinology on the way an individual evolves, how he thinks? And I'm questioning: are we really the master of our thoughts? And one of my question is, when you are in a state of homeostasis state, I think that those moments you are in control of your thought. Otherwise, your body, your guts, your environment tells you what to think. And I don't think a forehead connected all the time. When you're under a situation, a stressful situation, the brain is working for a solution. you don't necessarily have the control over it.
Okay, with all the respect and with sincerely, all is well with that. But I'm, from my experience, there are so many people doing theoretical stuff, talking about philosophy. That's very nice. You have endless groups and people and meetings and so on that do that.
Life consuming.
But we are interested in bringing it to the clinic, you know, to the patient. When you are in front of a patient, how much does this help you or does not help you or is valid is really important for us as clinicians. So I'm waiting a little bit more. I don't know if Mohammed is in the group already because he volunteered.
Love of Life comes to me with these.
He is probably coming soon. I will tell him to come up. He volunteered to present a patient that he has already seen, and the idea is to present the patient quickly in the traditional way, because we all know to say depression, you know, hopelessness, and so on, and see if we can take it a step further to describe it as a brain-related disturbance. So there is someone with a microphone open that we are hearing him. Maybe you can silence your microphone when you're not on. Okay, now let's see. We'll give it a few more minutes. And I will just text him.
Oh.
Someone has a microphone open.
Love of Life comes to me with these.
Ivy, I will mute you, okay? Okay, and you can unmute yourself once you are speaking. Just a second. Sometimes people get confused with the timing, but he's on our time scale. Meantime, any one of you can give some feedback if you played a little bit with the program, with the Brain Profiler online. It's actually not a program, it is more like educational. Can you say something about it from your experience? I can just show you. This is actually it. Very simple set of findings from the patient. So you have like hallucinations, hallucinating of association, and so on, the symptoms, phenomenology, and then combinations. So you can have hallucinations with hallucinating of associations and so on. So these are supposed to be the major, most frequent combinations that you can find on the patient. And as you can see, once you, for example, let's take something simple like hallucination of associations. Once you press that, you get, did you play a little bit? You get this diagram showing you in red. Red will be disconnection dynamics, meaning that the network, this is part of actually the executive functional network is disconnected and different hubs are statistically independent. And if you need the description, here is a short description. Executive central network involving dorsolateral prefrontal cortex, so the regions and the disconnection. And here, in the treatment, is what you will get from the imaging and some suggestions about the treatment. Did you get the chance to play with this a little bit? I don't know. Okay, is Mohammed Hassan with us? Yeah, here you are. Hi.
Hello, Professor.
Mohammed has volunteered to talk a little bit about a patient that he has seen. Do you want to say a few words about yourself and then
Yeah, sure.
you remember that you volunteered?
Yeah. So, hello everyone. So my name is Mohammed Hassan. I'm a psychiatry fellow based in Qatar in a hospital, Turkish hospital called Hamad Medical Corporation. Department of Psychiatry and the Hamad Medical Corporation. So I've been an avid member in the neuroanalysis network since its inception. I'm quite proud of that. So I'm here. I volunteered to present a case that we, both me and Professor Khaled, presented since the initiation of the first version of the Brain Profiler platform. But now we modified the presentation to implement the new platform, second version, I believe. So yeah.
Okay. I just made you host, so you can share
Sure.
if you want to share something.
So not quite sure. Can everyone see the presentation?
Yeah, I can see it.
I just okay. So is it obvious here or is it visible?
I can see it.
Sure. So okay. So the presentation here is about a case that we all, or the majority of us as practicing psychiatrists, see and deal with every day in our daily practice. It reflects the complexity of our patients, of our clinical data that we encounter on a daily basis. However, it also highlights the shortage and the shortcomings of our current diagnostic system, which is basically DSM, Diagnostic Statistical Manual, in the USA, Canada, and other practices that use the same system, and the ICD-10 as well, and 11. So I have no conflicts of interest disclosed, and the current opinion I present here is my sole opinion and doesn't reflect the opinion of Hamad Medical Corporation or my department of psychiatry. So basically, as a short introduction of our patients here, he's a male, divorced in his early 30s. He lives with his family and he works as a school supervisor, and he carries the diagnosis of major depressive disorder with an anxiety spectrum disorders according to DSM-5 diagnosis. So basically, the patient was admitted on that date and he was discharged after spending a comparatively lengthy period in our psychiatric and patient facilities, 45 days, which reflect that his clinical presentation was quite serious. So the patient presented from our emergency department to then transferred to our psychiatric inpatient after worsening of his depressive symptoms in 2 or 3 months before his presentation, with intensification of suicidal urges and ideas and plans 2 days prior to his admission. And that was the reason of his admission. So to start with, few months before his admission, he started to experience a relapse, a severe relapse of his underlying mental disorder. So basically, he presented with depressive symptoms, typical classic depressive symptoms, pervasively severe low mood most of the days, every day, talking DSM-5 here, with early morning worsening, in addition to severe anhedonia, which is basically severe inability to enjoy every aspect of his previously joyful life. Additionally, he started to experience severe fatigability and tiredness and low energy, which significantly affected his functionality and impaired his occupational level. Also, he had been complaining of significant vegetative symptoms in the form of poor concentration and psychomotor retardation, manifested as slowness. And that contributed significantly to his impaired functioning, as he had committed several concentration problems and errors at his work, which affected his function. In addition, he had been complaining of helplessness, hopelessness, and worthlessness about himself, all big triad of depression. Additionally, he also exhibited symptoms that were not classical of depression. He started to experience severe and frequent classic panic attacks most of the days, which were more frequent than his baseline, and they were classic panic attacks. I didn't highlight the symptoms just for the sake of time. In addition, he was experiencing significant heaviness over his shoulders and arm, as if a heavy object lying on his shoulders. Also oversleeping. Rather than insomnia, it was hypersomnia. However, although the duration of the sleep was quite excessive, it wasn't refreshing and the quality of the sleep was very poor. Additionally, and quite importantly, he was complaining of overeating, in particular craving of carbohydrates and other high caloric materials, which added extra pounds to him, and that added to his distress, because as I'm going to discuss later on, he was complaining of serious and significant weight problem. These symptoms were quite progressive before his admission, and with the progression of his symptoms and worsening of their severity, he was starting for the first time ever to complain of frequent self-harming and suicidal thoughts and urges. In fact, he was thinking every day of slashing his arms with a knife, and he was thinking before admission of overdose, a thing that never occurred before. He actually, adding to that scene, he attempted to slash his wrist with a knife blade one day prior to his admission. But thankfully, unfortunately, that cut wasn't deep enough because the knife wasn't sharp. He preferred to see a psychiatrist before something more serious occurred. And during that admission and presentation, there were no symptoms indicative of any psychotic or manic process, or other diagnostic criteria were fulfilled. And he was adherent to his medication and compliant to it before admission, however, with no improvement. Since 2017 till his admission, he was maintained on these 4 medications every day, and he was quite adherent taking them. He was following regularly in the clinic. And it's a mixture of antipsychotics, antidepressants, the famously known as California Fuel, mirtazapine and venlafaxine, with augmentation with quetiapine and propranolol for anxiety. So, in terms of past history of this patient, medical history was significant for bariatric surgery. As I mentioned, the patient had been having significant weight gain problems and obesity problems, which were adding to his psychological distress. He had sleep gastrectomy 7 years ago. Otherwise, it wasn't significantly for any other surgical medical history. For the past psychiatric history, we have a quite rich history here. Starting 2008, apologies, following a marital discord, he's been having symptoms indicative of a generalized disorder, which are pervasive preoccupations and rumination about anticipating negative events in the future, in addition to comorbid secondary anxiety symptoms, mainly physical in terms of musculoskeletal tensions, GI problems, and disturbed sleep. Starting 2014, he started to experience symptoms of depression, which were comorbid with excessive alcohol intake, which he used to self-medicate for anxiety. He was evaluated by multiple services, psychiatrists, both in private and governmental sectors, received multiple diagnoses: depression, anxiety, substance use, social anxiety, among others. And he was prescribed and maintained on various medications, psychotropics, antipsychotics, anxiolytics, benzodiazepines, SSRIs, etc., yet with no significant benefit. He was admitted before that presentation. In May 2016, he was admitted for a short time then. It was only 2 weeks, with an impression of major depressive disorder and a plethora of anxiety disorders too, social anxiety and panic disorder, with claustrophobia, due to the same symptoms as his current presentation, which were depressive symptoms, atypical symptoms, and panic attacks. In 2016, he received his first set of ECT, electroconvulsive therapy, which were the only significantly improving therapy he ever received. It was the only treatment he received since 2008 till 2016 that resulted in significant improvement of the symptoms, both anxiety and depressive symptoms. However, that improvement unfortunately wasn't sustained, only lasted for 6 months. And he was maintained on the 4 medications I mentioned earlier: quetiapine, antipsychotic, venlafaxine, mirtazapine, and propranolol since 2016 until 2019 with negligible effect. As I mentioned, he was regularly adherent to his to attending his outpatient clinic visits and taking his medications. He never received any psychotherapy prior to his admission, and interestingly, he never had any suicidal or self-harming thoughts or attempts prior to his admission. And that reflected the severity of this admission. So family history was also significant and rich. He had significant family history of similar presentation in his of anxiety and depressive symptoms in his mother and brother too. And his father had also an unspecified mental disorder that wasn't treated. For social history, he completed his higher school level education. However, his scholastic achievement wasn't adequate enough, and it was below average to his peers. He had suffered from various family conflicts and discord, and he had troublesome childhood too. So he had a couple of businesses in the past, however, they were not successful, and he was working as a high school supervisor for students, supervising their activities from 2001 up to now. However, as I mentioned, due to the severity of his symptoms, his attendance to his work wasn't sustained and was interrupted with numerous sick leaves owing to the severe concentration problems and severe anhedonia and psychomotor retardation of slowness. Yes. So, apologies for the repetition. And interestingly, he used to enjoy a couple of hobbies, mainly painting and traveling, and he described himself as an introvert. For substance history, he used to consume alcohol heavily since the beginning of his symptoms, mainly to self-medicate and self-alleviate his anxiety symptoms. However, that didn't cause him any medical or psychological problems at that time. And he is a heavy smoker. He smokes more than 1 pack a day. And he had infrequent history of cannabis misuse long ago, but not currently. And no significant forensic history. So for the physical examination on admission, it was unremarkable except for morbid obesity. His BMI was quite high. His weight was 137, mainly secondary to his antipsychotic quetiapine and antidepressant mirtazapine that he's been receiving for more than 4 or 5 years prior to his admission. When we repeated his labs and we collected blood profile, it was significant for hypothyroidism, which were never investigated nor medicated before. So shall I just proceed, or shall I pause for questions now?
Yeah, let's go. If we can go a little bit quicker about the mental status, just emphasizing the symptoms that he had.
Sure. So a mental status exam on first presentation and admission, it was significant for overweight belt, as I mentioned. He was quite distressed on presentation with interrupted eye contact owing to his severe anxiety, and his speech was of below average volume and tone owing to his depression. Mood was miserable with lower dysphoric affect, and thought process and form of control were unremarkable, except for severely evident suicidal thoughts, plans, intents, and urges and gestures. In fact, he was noticed looking for something to hang himself while in the hospital, while in his room, and he was maintained on one-to-one nursing observation to prevent any suicidal attempt or behavior during hospitalization. In addition, there were evident hopelessness and anhedonia, in addition to the full set of big triad: hopelessness, helplessness, and worthlessness. So for the hospital course, after admission, he was noticed to be extremely psychomotorily retarded and socially isolating himself. He wasn't engaged in any activities at all, neither with his therapist nor psychiatrist. He wasn't engaged in any of the nursing activities or other behavioral rehabilitation programs. So we initially maintained the patient on his home medications, which again, as I mentioned, antipsychotic quetiapine, mirtazapine, and venlafaxine, in addition to propranolol for anxiety. And after we found the hypothyroidism in his labs, we supplemented the regimen with levothyroxine 100 micrograms, owing to its augmenting antidepressant effect. So we performed multiple serial assessments, interviews, and reviewed his previous charts and gathered collateral information and observation. We concluded, based on DSM-5 criteria, that the patient suffers from a diagnosis of major depressive disorder with atypical features, in addition to comorbid panic disorder and dependent personality traits. So it's quite a mouthful diagnosis, honestly. So after that, the patient underwent ECT, which was the only completely successful treatment he had in the past, and not surprisingly, he experienced significant improvement after 10 sessions. We removed quetiapine, giving his significant overweight problem, and we supplemented and augmented his current regimen with lithium, owing to its effect, in particular on atypical depression and its anti-suicidal and antidepressant activity. The patient agreed finally for psychological work, mainly CBT and other behavioral techniques to target both anxiety and depression. The patient experienced a significant improvement with the progress of hospitalization. Sleep, energy, and the rest of his depressive symptoms gradually improved, started to be engaging, no longer suicidal thanks to ECT and lithium, and his big triad vanished, and he was allowed for multiple trial leaves with satisfactory outcome until his final discharge. Up till this moment, the patient is regularly adherent to his outpatient visits and medications with excellent outcome, and he hasn't been admitted any longer up to now.
Very good, very good. Yeah. Okay. Now, yeah, this is what I was asking. The next one. Okay. Yeah. Continue.
Okay. That's a brief section. I hope I made it more lengthy. I think it would be more appropriate a platform with us so they can follow up the case. So we're dealing with a case of depression and anxiety and underlying personality disorder. And we used the second version of Brain Platform to formulate the case. So can everyone see the chart?
Yes.
So this is in terms of the depressive symptoms of the patient, the depressive diagnosis. So this is a default mode network, and these are the halves of the posterior cingulate, I believe, Professor, and the dorsolateral prefrontal cortex, and the executive network. And when we implemented the Brain Profiler platform, it will show us a brief, succinct formulation of the case, which is de-optimization dynamics with growing mismatch. So it's a mismatch between the executive networks and default mode network. And the rigidity in this network emerges as depressive features that the patient experienced. Okay. And the good thing also about the second version of the brain platform, the brain profile platform, is that it also provides a short and brief summary of the current approved treatment and the current novel treatment that can be used. So if the attendees kindly followed with us in the brain platform website, they can see the approved treatments and the proposed treatments for depression, which is SSRI, mainly hypothetically to induce neuroplasticity. In addition, the platform proposes other neuroplasticity-inducing agents, mainly psychotherapies like CBT and virtual reality, in addition to other neurostimulatory intervention, TBCS, TMS, and also, I believe, also ECT. And basically, it suggests all interventions that can increase and facilitate plasticity and reduce free energy that emerges as depressive symptoms. So that's the first axis in the diagnosis, which is depression. If we moved to the second label the patient carries, which is an anxiety, and here we're dealing with panic disorder, we see that I'm sorry. Yeah, also, I make it as brief. So basically, there's instability between the hubs, the dorsal prefrontal cortex, posterior cingulates, which emerges as an anxiety features. And also, the beautiful thing also about the platform is that it gives you a small and brief succinct a list of treatments that can be utilized in the case. Also, which can be also very useful for patients' education. As we know, for anxiety, anxiolytic like benzodiazepines and serotonergic agonists like buspirone, in addition to SSRI and the rest of approved antidepressants, work hypothetically through inducing neuroplasticity, which will make more adaptive connectomics for the anxiety symptoms. In addition, it also provides information about a list of neuroplasticity-inducing agents like TMS and other neurostimulation techniques like TDCS, transcranial direct current stimulation, in addition to virtual reality, which interestingly have a calming, meditative plasticity-inducing effect, probably because of their reducing anxiety through modifying concentration. And thirdly, if we followed also, as we mentioned, the patient carries a labeled diagnosis of personality disorder, in particular dependent personality disorder, the platform also provides us a small and brief formulation showing that it's hypothetically due to immature, biased, rigid default mode network. And it provides you again with a list of novel treatments that could be utilized. One of them is approved, which is psychotherapy, which results in experience-dependent plasticity, in addition to other neuroplasticity-inducing agents like virtual reality, which also was used in depression and anxiety. In addition, it suggests that any intervention that will enhance development and neuroplasticity, including enhancing small node network maturation. So, and honestly, I personally like that diagram because it gives a summary of the whole patient symptoms, which is anxiety, depressive disorder, and panic disorder, and dependent personality disorder. And it combines the three labels in one diagram, and it also provides a small and short succinct formulation of the patient symptoms. So it's the whole hub error and the whole global network problem that emerges and produces these symptoms, mainly in the form of immature biased default mode network. Okay, and here's the hub that produced earlier depressive symptoms, the posterior cingulate and the prefrontal cortex, in addition to the other hubs, other core network globulopathies that resulted in anxiety and personality symptoms, personality disorder symptoms. So,
Great, great, great. Okay.
so I finish the presentation. Thanks a lot for your time. And if you have any queries regarding the presentation, kindly please do not hesitate to contact me. And thanks
Wow.
for Professor Pellet for allowing me for this honorable moments. And thanks for the attendees for being patient.
Okay, I will take over now. First of all, I'm excited. I'm really, really excited to see how you made it perfect. I mean, I see for the first time, instead of a psychiatrist, a psychoanalyst, which means if you noticed, he moved from description, which doesn't say anything about etiology. Like in medicine, you say appendicitis, a place in the body and what happened to it. And he moved to a set of descriptions which are a location in the body that will be the whole brain, cortical brain organization, and the specific pathology for each of the symptoms. So the disconnection, the optimization, and so on. This is the new terminology. This is the way that the future psychiatrist will talk. And if you didn't understand what he said, then it's time to go back to the workshops and learn it, because this is the future. And if you can go out from the sharing, then I will share my slide. I don't know if I can share it over your one. Can you unshare your screen?
I'm trying to.
It's in the green in the bottom. Maybe I can help you.
Sorry.
Host disabled. Okay.
Oh, stop sharing. Okay.
Okay. Now let's see if I can share one. Okay. Maybe you need to make me a host now because you're the host. So do you know how to do it? If you go into the share, no, if you press on my page, maybe you can make me a host again, because now you're the host. Anyway, we can do even without it if you don't see. Let's see. Yeah.
Professor, I think it's done now.
Okay. Yeah. Okay, great. Okay. Okay. Can you see this drawing? So basically, we saw a patient who has depressive symptoms, severe ones, and what do we know as the most basic, like obvious about the depression when it actually responds? In this case, it didn't respond very well to medications, but let's say it responds to ECT. So what's in it? So in this diagram here at the bottom, you can see the plasticity that Mohammed talked about. And you can see that you have here on one side, you have a few dendrites and spines, and then with treatment, there are more dendrites and spines. We know that the antidepressant medications are synaptogenetic. They create more synapses. They are plasticity inducing. And we know that ECT does the same thing. And recently, we also see that other types of treatments, new ones like TDCS, are also involved in some kind of plasticity induction. Now, this is easy to say, okay, you have depression, you have antidepressants, they increase plasticity, but what does that mean? What does it mean increasing plasticity? So in order to understand that, we need to go to a different level, to someone who wrote a lot about it, called Carl Friston, and he described the brain as a system. And this is just, we started this in the beginning when one of the participants said about the importance of the environment. Well, it is really critically important because the brain always continuously predicts what is going to happen in the environment and internalize it and represents it. So in a way that the level of organization in the environment and the level of organization of the brain are always balanced all the time. And the brain tries to minimize the differences between the internal representations of the brain and the external events. And this is called by the person who described it, and he's an opinion leader in that. His name is Carl Friston from London. He termed it a Bayesian brain because he calculated these changes as Bayesian, the Bayesian statistics, the prediction, doing a prediction, okay? And now we are beginning to understand why plasticity is so important. Why? Because if the brain is plastic, then it's adaptable, it's changing easily. And the environment is changing all the time. So if the brain is more changeable, it will be able to minimize more quickly and more efficiently the difference between the environment and the internal representations of the brain. And by doing that, it reduces a difference, which is called delta, or sometimes it was called free energy. Okay, so the whole brain moving from a mismatch to a better match with the environment is, this movement reduces all the time, or tends to reduce the delta, reduce the free energy. And the whole dynamic of that, if it is related to elevated mood, then you can understand the linkage now between plasticity, whole brain dynamics, and mood. And now you have a model that can explain why, actually can explain two types of depression that we see all the time. We see reactive depression, something in the environment causes the depression, like someone is dead, there is some stress or so on. And on the other hand, the ability of the brain to be plastic, plasticity, is also related to a depression that sometimes you see coming out of nothing, without any reason. There is no reason, there is no stress, but still there is out of the blue a depression. On one hand, it is probably related to something that hampers or impedes plasticity dynamics. And on the other hand, the changes in the environment. And sometimes you have both of them. If you take a person who is very old, demented, the plasticity is reduced, and now you change his environment, you send him to a foster home, some big change in his life happens, then the delta increases because the plasticity is reduced. It cannot adapt to the environment, and the environment changes, so the delta increases. And then you have these two things together, both the depression that comes out of nothing and the reactive depression. Okay, so now we have a set of hypotheses going from plasticity to the brain. Now, in this specific patient, very interestingly, you have other two things which is evident in it. There are more, but there are two major things that I noticed that are really relevant to inducing the depression in this model. One of them was the hypothyroidism. So the hypothyroidism, we know today that many hormones, especially the thyroid hormones, are actually also neurohormones. So this might suggest that the thyroid has some kind of influence on the plasticity. So if we assume that changes in hormones, in neurohormones, and the thyroid itself is causing depression, how is it causing depression? Causing depression by reducing the plasticity of the brain, and the normal changes in the environment do the rest of the job, and the delta is increased, the free energy is increased because the brain cannot cope with the changes in the environment. So this is one thing that comes very nicely in this case. And the other one, which is more major, we have a suggestion here that this person had some kind of many personality issues. Let's say, maybe it's not very evident that he had a personality disorder in the full sense of the thing, but still we have enough information to understand that he had a problem in upbringing, in his psychological history, and this it could be some kind of, let's assume that it's related to personality changes, And now what is personality? Personality is related to internal representation. So we know, if you see on this slide, we know that when you go up, in the beginning you don't have many neurons, then you have many neurons which are disorganized, and then you have this like pruning effect when you become an adult, okay? And we know, this is taken from a video I sent you. When you have a child brain, you can see this schematic representation with all these connections here. And then when the person matures, you have these less connections, but more organized, and organized in a way which is called small world network. Today we know that the brain is organizing as a small world network, okay? So this, if you look at this, this is nice because you can imagine like cardiologists, they have the EKG, they have a schema they can look at and say, okay, the cardiac insufficiency is caused by this and that. In the coming future, hopefully we will have something like this, where we will look at it and say, oh, this patient is suffering from small world network disturbance. Okay, you can see here that he has many entries in this hub, and that's not normal for his age, and so on. And we also know that the brain represents the environment. First, it represents the body. So we know about the homunculus. There is a map, actually, of our body represented in the brain on the cortex. But it can also represent concepts. And we know from working with artificial intelligence, this is how artificial intelligence actually works. You have these units here, which can be anything like neurons or other units. And when they are connected, they can represent a set of units, can represent, let's say, a banana or anything. But actually, the brain can represent everything. And it represents also interpersonal relationship, and it represents yourself and others. And that's where object relation psychologists excel, because they actually describe, in object relation psychology, the object is an internal representation of someone, of a person. So you can know about this person. And your interpersonal relationships depend on how you are represented in your brain and how your friends are represented in your brain. So if you represent them correctly, you are adaptive in the environment. If you represent them incorrectly, you make mistakes and you are miserable. So personality disorder would be related to the problem of internal representation, and that will cause an increase in the non-adaptive system and the increase in the delta. So the personality disorder, per definition, with this hypothesis, is causing depression. And actually, everyone who works in the clinic knows that when a patient with personality disorder comes to your clinic, he will not tell you, doctor, I have personality disorder, as if it was written here. No, he will complain about being sad because, and when you check him, you'll see that he's sad because he's not getting along with everyone, okay? So he's not having a relationship, so he's sad. So he quarreled with someone, he's sad. He was fired at work because he did not get along with the colleagues or with the boss, so he's sad. So you'll see that it is secondary to his inability to adapt. His inability to adapt is because his internal representations are disturbed, okay? And so we have this element in this presentation, which is really nice. We have the hormones here. Now, when a system is destabilized, it means that the whole system becomes unstable. What does it mean in networks? In networks, it means that one unit affects the other unit. There is a mathematical formula about that, the activity of one neuron, and then the influence on the other neuron, and there should be some kind of value that you get in the connections. We'll not go into the mathematics, too complicated, but what you can imagine is that there is a strain on the connectivity. The connections are not satisfying the mathematical equation between them, and the whole system becomes more unstable. And this will accompany many of the disturbances. So, and this will cause, as an emergent property, it will cause anxiety. So we also have anxiety. In most psychiatric disorders, there is a tendency to miss that, because if you have someone with very prominent psychotic features, then you concentrate on the psychotic features, but they're typically anxious, these people. And with anxiety and depression, they go together really well, especially with personality disorder. So this can explain this typical phenomenology. And we must remember the idea of emergent property. The idea of emergent property is how come a physical system has a psychological effect. how come a system of 10 billion neurons generates something psychological? So the whole brain dynamics can cause an emergent property, a property which is not part of the elements. Each neuron doesn't have psychological features, personality and mood and so on, and not even a million neurons, but 10 billion neurons together, when they act in certain dynamics, they can generate emergent properties. And these emergent properties, this is something very well known in physics, where you have a characteristic of a system which is not part of its elements, and it's more than a part of its elements. And this is typically related to systems which are non-linear, dynamic, and complex. And we will not go into that. There is mathematics for complexity. There is mathematics, believe me, for emergent properties. We won't go into that as clinicians, but we will remember that it exists, and this explains as an explanatory power to the fact that, that we have these symptoms. So now you can get the idea how we move from a description. The patient said, I'm sad, doctor, what do I have? Oh, you have depression. No. Now there is a psychiatrist, a neuroanalyst, okay, like Mohammed, and he can tell his patient, look, your brain, in your brain, this and this and this and that. This is things that are real, they are physics, they relate to your environment, they relate to your past history, they relate to you having obesity, maybe you don't have enough, you have a little bit of hypoxia, which reduces the plasticity, you have, everything falls into place, and also the treatment. So now we understand why does ECT help most? Because it was most effective to increase the plasticity. Okay, the medication didn't work because maybe, or they worked partially, maybe because they weren't enough for the plasticity. Now, can we think about something new? Does Mohammed have an advantage over all the other psychiatrists? Yes, he has, because now you can think in terms of plasticity inducing. And for example, there is something that comes up recently, very controversial. Not many believe in it, like the TDCS, for example. And many people joked about it and thought it was nothing. And it looks like it could be effective. But why? Because it's doing this thing of increased plasticity in the prefrontal cortex. And maybe in the prefrontal cortex, the plasticity induction is most effective because it is a hub of a network and it can increase the whole plasticity for the whole network. So for example, now trying something new is an advantage. And another advantage is that in the coming future, for you young generation, I'm not talking about me, people, don't be offended, those of you who are at my age, I'm not sure we will see that day, but the day that some brain scientist will come to a psychiatrist and say, look, I developed this way to control the brain. There is a lot of neuromodulation recently. There are a lot of technology, a lot of new things that are coming up. He will come to you as a psychiatrist and tell you, okay, you have this patient here. Tell me what's wrong in his brain in physical terms, in algorithmic terms, in terms of space and time, okay? You know, the time scale for depression will be 1.5 months. The time scale for hallucination will be millisecond range. The time scale for personality disorder will be long life from the birth till today. So in the time scale and in the algorithm of a small world network, mathematically you can calculate it. Tell me for this specific patient, what is the disturbance? Just like cardiologists will look at cardio EKG and see what, you know, you have these disturbances like ST elevation and QT prolongation, and all this terminology is the terminology of a working system, physical system. And here you have the neuroanalyst of the future. He will be able to cooperate with someone who is doing neuromodulation, and better be that he will be the neuromodulator to create the perfect brain pacing, brain modulating, brain optimizing, whatever device that will cure the patient totally and actually erase his symptoms, okay? So erasing his symptoms would be making him just like you and me. And I'm talking about severe cases like psychosis and so on that could be also erased. So I don't know if what I'm saying, we have like 5 minutes, then we can have your impression about it. and what do you think about this way of looking at things? But I think it's really, for me, it's really exciting to see for the first time someone who is able to use this physics language and the etiological description for psychiatry. I think it's a very impressive effect, so I like it. So now we have like 5 minutes to the hour. It's time for anyone who wants to say something or participate. And if you talk, just remember to your microphone so we can hear you. Unmute, Today we are living in the unmute life because of the coronavirus. Silence. That's nice.
No, I would have something to say. So I'm not a psychiatrist or a psychologist or whatever, but I've been studying a lot about it. Now, I've said something somewhere that in our brain, what we see, everything that we think we know, is just a projection of what's going on into our brain. I mean, the color we see, it's all wave, the sounds and everything, the senses, it's all connection, it's all frequencies that, and in our brain, we build pictures. What we see in front of us is projections like within a movie. And those plasticity, one of my questions is, what is the relation between plasticity and the level of cortisol in the bloodstream when somebody is always overstressed? So that does change the mood. And there's another term that's been used a lot, it's resilience. And I tied resilience with plasticity. And then plasticity works well when the brain is kind of soft, especially the white tissue. It has to be well irrigated and clean and stuff like that. When it comes stiff, it's very hard to do new connections and prune some connections, because everything we think, the way we think about it, it's based on connections. And it's like learning to going dancing or biking. It's all connections.
Okay, I basically correct, totally correct. What's interesting about, sometimes it's interesting the thing of fashion, that you have fashion. Everyone talked in the past about the genome. Now everyone talks about the connectome. So they invented this name, connectome, instead of saying neural networks and connection. So you have this nice name, connectome. And now you can add to it connectomics, pathoconnectomic, connectopathy. And then you have this idea of illnesses becoming related to the connectivity. And talking about connectivity, it's endless. You can go in this deep and talk about, how to generate representations with the connections and so on and so on. And it's actually correct. And now, the other thing that you talked about was cortisol and its relation to plasticity. Yeah, all these neurohormones and even oxygen is neuroplasticity in the brain, and the exercise, and many things are related to that. But what happened till today in psychiatry, that psychiatrists, because they follow the same way of thinking in other types of medicine, where you have a direct connection between a gene or a neurotransmitter or a molecule and the whole phenomenology, then people are trying to look at one thing, let's say cortisol, and a whole range of some kind of disorder. And doing this connection, a linear connection between one molecule and the whole brain dynamics does not work, because you cannot have a linear connection because the brain is nonlinear. Having been essentially nonlinear dynamics, then if you look for a linear connection in a nonlinear system, it's like walking with glasses that see only straight lines.
I agree with you.
and be
I
as
agree with you.
that you don't see
Nothing is linear.
circle or something like that.
Nothing is linear. I agree with you.
Yeah.
But
Yeah.
here I have an article that came out this year, filling down a systematic review of the gut microbiota in anxiety, depression, and being irritable. So it's not only the brain as itself, it's the whole body. I mean, if the ways I feel sometimes the way they do the study of the case, they go through the symptoms, but the study, it's not fully done probably. Physiologically, it has to get a better analysis of the physiology, the endocrinology of that person to see why are the unbalanced place. Try to fix that at first sight, and then will remain the real problem or find the real cause of it.
Okay, our time is a little bit up. Is there anyone who wants to say just last one short comment or something like that? I hope we can find someone who volunteers for next time. And if you want some help with the workshop, and you can contact me also directly by email. Maybe I would love to instruct anyone who wants to directly in a Zoom meeting. And I also would like to think a little bit about how we continue. In the past, we said maybe we will do twice a month. Then we moved to once a month. Last time there were many more people, and now there are a little bit less. So we're always thinking how to proceed, and maybe we can do some kind of discussion using a group, a neuroanalysis group at LinkedIn, just by writing. Maybe there is a video which is really nice about the DSM. You will see it, you won't believe it, that this is how the DSM was constructed. I would like to share it with you and hear what you have to say about it. So I can share it either by the email or with a WhatsApp group, but for discussion, I don't think anyone wants a lot of indications on his phone all the time, these notices. Maybe it's better to move it to the LinkedIn group. We have a LinkedIn group called Neuroanalysis, and in a group you can actually on a group page we can have discussion. So maybe I will try that. I will tell you about it in the email and in the WhatsApp. Okay, so thank you very much for being. I recorded this, so I will send it to everyone. And really, I really liked your presentation, Mohammed. So hopefully someone else will be able to present next time. Okay, so bye for now. We are ending.